We will move on to the next speaker, Dr. Gaurav Sen, who's going to talk to us about small intestine and pancreas making the move.
Thank you very much, chairpersons. And thanks to Ramdeep for inviting me to talk on this venue. I was just having a little think about it. I'm like Ramdeep, I'm a Calcutta Medical College graduate, and I left Calcutta in October 3rd, 1998, which is exactly 25 years. So it's great to be back after 25 years to come and talk to, and met a lot of our old friends and some of my teachers as well, which was excellent. So I think this is the last talk of the session, and I can see afternoon after the fantastic lunch, people are a little bit sleepy. So I think I wanted to keep this a little bit light, okay? And thanks, Ramdeep, for telling us that this needs to be an evidence-free zone. We need to talk about what we feel is the right thing to do. I have no conflict of interest in this talk, obviously. The opinions expressed here are all my personal view and what we have seen happen in Newcastle. I must say Newcastle doesn't do intestinal transplantation, so this move from liver to other organ transplant will predominantly include my experience in pancreas transplantation, and we are a kidney transplant unit as well, but I have got personally no experience of doing intestinal transplantation, although I have experience of intestinal organ retrieval during cadaveric retrieval. So this is where Newcastle is, and it's a very pretty city. That's the Tyne Bridge, and the claim to fame of Tyne Bridge is it's the same design as the Sydney Harbour Bridge, and it was designed by the same guy, and the same engineering firm built it. So you can see the similarity, why it is exactly built like the Tyne Bridge. Obviously, the Sydney Harbour Bridge is it's bigger. But why is Newcastle famous? Newcastle is not famous because of the engineering part of it. Newcastle is famous for that little tiny stadium in the corner that you can see, and that's the St. James's Park. Krish is quite interested in that, and that's the home of the Newcastle United football club, and the whole city and the region is crazy about football. And so I thought I can't really give a talk here without talking about the football from Newcastle. And on Wednesday, Newcastle beat PSG, so I had to show this because the whole city went absolutely crazy. And that's what Newcastle is famous for. But for this afternoon, we are going to talk about the Institute of Transplantation, which Newcastle is famous for. So this is the only transplant institute in the UK which has got all solid organ transplantation, including cardiothoracic, under one roof. And this is quite a unique thing that we have in Newcastle. And it was built while I was there, so it's quite new. So it is based at this hospital, Freeman Hospital. It's usually the weather in Newcastle is quite grim. It's quite cloudy. It's very cold in winter. The hospital is located bang in the middle of the city, surrounded by all residential areas. These are the new parts of the hospital, the new cancer center, and the Institute of Transplantation, where we are going to talk about why I think that that's a good idea and helps to make a move from liver to other organ transplantation. Now, do we need to make that move? I mean, I know probably Ramdeep is quite keen on it, but do we need to make that move? Let me just say a little bit about what the Transplant Institute does. You will see the data is slightly skewed in the next slide, because this is data from what we did in the calendar year 2022. We are a big organ retrieval center, part of the National Organ Retrieval Service, or NORS, which runs the organ retrieval in the UK, and we did 208 multi-organ retrieval call-outs. That doesn't mean all call-outs ended in an organ transplanted, but 208 times we attended other hospitals for organ retrieval. And we did a combination of kidney, liver, pancreas, and islet transplantation. You will see that the number of liver transplant was quite small, and we are the smallest liver transplant unit in the country. And we had a bad year last year for various combination of reasons, but hopefully this calendar year we have already done more than 44. So hopefully this calendar year we will be doing around at least 50, which is what we really should be doing based on the population that we serve. So this is the whole transplant scenario in the UK. And if you look at it, I know it's a very busy slide, but it's a list of all the transplant centers, combination of kidney, heart, lung, liver, pancreas, etc. If you look at it, if you look at maybe the second from the top, which is Birmingham, which has got a total number of 459 transplants done, and this is in the calendar year, April to March this year, April last year to March this year. And of that 459 transplant, it is a combination of a big number of kidneys, nearly 200 kidney transplant, and 220 liver transplantation that they have done. The biggest liver transplant units are Birmingham and King's, which does 220, I don't know how many King's did last year. It was 213 in the last calendar year. That's the sort of volume of liver transplant they do. If you look at Newcastle, on the other hand, we have done 239 transplants, but it's a combination of various different things. So we have done 127 kidneys, we have done 11 pancreas, 35 livers, 40 heart, 25 lungs, and 1 multi-organ, which is a heart-liver combined transplant, because we are one of the centers for adult heart-liver transplantation. So for me, the thing about Newcastle is the variety, and not just concentrating on one organ transplantation. There are definitely advantages, but there are disadvantages to it as well. If you look at what happens with liver, pancreas, and intestinal transplantation, because the topic that we wanted to talk about is, can we make that move? And I'm just talking on the basis of what's happening in the UK. If you look at the liver transplant units, there are 7 liver transplant units on the left-hand side. There are 8 pancreas transplant units. But if you look at them, there are only 3 of those pancreas transplant units have got liver transplantation as well. All the other pancreas transplant units obviously has kidney transplantation with it, because simultaneous pancreas kidney transplantation is perhaps the commonest sort of form of pancreas transplant that we do. But only 3 of us actually do liver transplant as well. So if you look at then the small bowel transplant unit, there are 2 units which are pediatric designated units, which is King's and Birmingham, and there are 2 adult, Oxford and Cambridge, out of which Oxford is the only one which does pancreas, and it doesn't do liver. So it is not really, what I'm trying to get at, is not really a sort of a gradual progression from liver to kidney and pancreas. So it depends on the experience of the unit, but what is very, very clear that you do not necessarily need to have liver transplantation in order to move to the others. The units which perform pancreas and intestinal transplantation as well as liver does not necessarily have the same team performing the liver, pancreas, and kidney transplantation. For example, in Newcastle, there are 3 of us who are always present for all pancreas transplantation, because we do only a maximum of up to 15 a year. So if 12 of us are doing 15 transplants, we would probably be doing 1 transplant a year, which is not enough to maintain the volume. And I think volume is important, because that's the only piece of evidence we can say that high volume centers in complex surgery definitely produces better results. But if you look at the volume in the UK, there are only 10 patients waiting for small bowel transplantation at present. So therefore, if I suddenly in Newcastle decide that I want to do pancreas transplant, I want to leave pancreas transplantation and would go on to doing small bowel, it will not be a great thing to do. I think what is required, and I won't take too much time, I think what is required is a robust assessment of demand for any new unit starting on transplantation, rather than the concept that we can do it. There has to be a very motivated team of physicians which drives them, because as we have seen in pancreas transplantation, unless the diabetology team really drives the program, it is very difficult to run an islet or a pancreas transplant program. I have also said that the management team needs to be on board, otherwise you don't want to take on a low volume, high risk transplantation when there is a chance of a lot of problems. The advantage, however, is that the teams are used to major procedures in a liver transplant unit, and by team I mean everybody associated with it. The allied specialties like interventional radiology, microbiology, etc. are all on board and used to it. And then the institution is likely to have an established reputation for public and patient confidence. In Newcastle, because of a combined transplant unit, we have an unique integrated post-transplant care ward, which gives us a tremendous benefit in looking after the patients jointly. And there's a joint care by physicians and surgeons, and we even work closely with cardiothoracic transplant surgeons, who are always a difficult breed to work with anywhere in the world, but we work absolutely fine. So the challenges are pancreas and intestinal transplantation and grafts are predominantly from cadaveric sources. So in a situation where, or in countries or systems where it is predominantly living donation, it is a major challenge. And patient safety and outcome needs to be the predominant driver of any new procedure rather than the technical ability to perform it. So I would like to conclude by saying moving from liver transplantation to pancreas and intestinal transplantation is not as natural a progression as it seems. And as I've already emphasized, the other stakeholders, especially the physician team which runs the program, need to be completely engaged in order to take on something like this. Experience of an established transplant unit is very helpful, there's no doubt about it, and multi-organ transplant units work extremely well, but I am saying this from a completely biased point of view. Thank you.
Take 2 questions before we wind up.
We can take one quick question, Doctor. I'm sorry. I guess there are no questions, so that we can move forward.
Thank you very much.
Thank you so much. I would like to request you all to please join in for a group picture. And I would like to request our previous speakers as well for the picture. Dr. Amit Rastogi and Dr. Gomati.